Good morning, everyone. So, without taking much time, I'll just move into my presentation. So, we have come a long way as far as orbital fractures management and the pathophysiology is concerned. It was first described by Mackenzie in 1844, and from there on, blowout fractures and then muscle entrapments were described, and then iliac bone for calvarial reconstruction came up, and finally, in early 1990s, we came up with the use of titaniums for orbital fracture management. So what are the key factors for management of orbital fractures? There's timing for surgery, the surgical competence of the surgeon, and of course the choice of implant on which I'll be talking about. So the perfect match that we when we look for our life partner in our life, these are the factors that we look for, which is like they should be compatible, non-irritating, flexible, they should be supportive, they should be available when we need them. Of course, some of us are worried about the figure and contours, and of course the wallet size also matters for some of us. So when we extrapolate these factors to our orbital implant, so they should be biocompatible, they should be non-allergic, they should be flexible and support the orbital contents very nicely, and the material should be available in sufficient quantity. They should be easy to contour upon, and yeah, they should be cost effective also. So we have a lot of options, and there's a lot of batteries of implants that we have come across, but only few of them are routinely used. The most common one, which still considered the bone, the gold standard, is the autologous implant, the bone. Allogenic and xenograft material are much of academic significance. Then alloplastic metals in the form of titanium is very commonly used nowadays. Polymers, silicon were very common in the past, but because of its complications, we have given away with silicon. Polyethylene, yeah, is used in many cases. And then nowadays a lot of talk about the composite implants. So what are the factors influencing choice? The defect size, the number of walls involved, how well the implant can adapt to the internal contour, whether we are talking about volume restoration or just about talking about functional impairment in the form of diplopia, and whether the repair is early or late. So we're just taking with some cases. So this is a patient who presented with diplopia after orbital fracture. As you can see in the picture, here you can see the patient is not able to elevate his left eyeball, and this is the CT scan picture. As you can see here in the left orbit is a trap door fracture. This is a classical teardrop sign, as we call it. So the muscle has the bone has fractured, and it has come back to its original place because of the pliability in young patients, and the muscle has just entrapped there. So these cases, they don't need much of a volume restoration. We just need to go and release the muscle, and that was what it was done here. So, and this is the post-operative imaging. So what sort of implant we have put here? It's an osteomesh, which is a polycaprolactone, and it's an absorbable material, since we are not concerned about much of the volume restoration. So once the implant has done its job, even if it gets absorbed, it's not much of a concern. Now this is another case. No, this is a post-operative result. You can see here, the elevation, which was limited in the previous picture. Now it has nicely been restored. Now another case, 13-year-old boy complains of double vision post accidental fall, and here you can see depression is limited in the left eye. So, and this is the imaging. So here also you see, this is the most common site where the orbital fracture takes place, the infromedial wall. So here there is a fracture in the infromedial portion, and the contents have herniated into the sinuses. So here also a fracture repair was done, and as you can see, this is a post fracture repair. The depression, which was limited earlier, it has nicely been restored, and this is the post operative imaging after the implant replacement, and this is the implant that we have placed here. So you can see it's nicely going up to the orbital the palatine portion of the orbital bone, and here the defect has nicely been covered. So this is the 3D recon picture of the same patient, and you can see the pre-contour titanium implant has nicely been placed, covering the floor and the infromedial portion of the orbit. Now another case here. So post-trauma, of course, and gross in ophthalmos of the right eye. And you can see large fracture of on the right side. Almost the floor is absent on the right side, and whole of the content is herniated into the orbit. So in these cases, and it was a late case presented to us almost after 3 months. So in late cases, rather than placing an implant, releasing the contents and restoring them back into the orbit is quite a challenge, because there is a lot of fibrosis, and on top of it we have a lot of vessels going into it, and there is a lot of bleeding when we try to remove those fibrotic materials and put it back into the orbit. So here we are much concerned about volume restoration. And this is the recon picture of the same patient, and this is a post-operative picture. You can compare it how nicely the in-ophthalmos has resolved. So in this case, we have put a titanium implant, and over that we have put a mid-pore to augment the volume. So in some cases, you can also combine titanium with mid-pore or bone with a titanium implant, as I will show in my next picture. Now here, this patient. So here, this is a post-operative picture of a patient. Right-sided orbital fracture repair has been done, and there is not much of in-ophthalmos, but the patient is worried, like how did such a big implant go into the orbit. So we routinely do this post-operative imaging. So here in this patient, we were able to convince him with this post-operative imaging that, see here, this is the implant which we have put into your orbit. And the point which I want to emphasize here, that with the conjunctival incisions, the scar is hardly visible. You can't see any scar, and it's very cosmetically acceptable as compared to the lower lid subciliary incision, which gives a bad scar and also in some cases results in ectropion. Now this is another case. Again, large fracture on the right side is gross in-ophthalmos, and volume restoration is a concern here. So in this case, what we have done, as you can see in this picture, this is a post-operative imaging picture. This is a bone graft which has been fixed with screws, and over that we have put a titanium implant, and the volume has nicely been restored. So as I told, you can combine implants also in some of the cases. So it's a bone graft with titanium mesh. This is another case. Again, a green stick fracture of the floor of the medial wall of the right orbit. Here you can see there is a fracture. The medial rectus has gone into the ethmoid sinus. The fracture element have come back, and the muscle has just snapped back there. So what we need to do here, we just need to we need to release this muscle, and we don't need much of a volume augmentation here. So in this case, what we have done, we have put a X-ray film in this case. X-ray film which was autoclaved and sterilized, and then it has been placed into the orbit. And this is the post-operative picture. You can see here the abduction which was limited, it has restored. So what are the surgeon's view of an implant? It should cover the entire defect, and it should conform nicely to the walls of the orbit, and as much as possible it should match the uninjured volume of uninjured orbit in volume. And it should not migrate, it should not cause hypertrophy of the globe, and it should not necessitate removal or debulking as is required in some cases of bone implants. So this is a paper by Potter et al. And as you can see nicely here, the porous polyethylene and metallic mesh, they score quite good on most of the criteria as compared to the autologous bone implant. So the perfect match which we talked about might not be practical in our routine life. And just to conclude, the search for an ideal implant still goes on, and it's a topic of an academic discussion. Is autologous bone the gold standard still? The time will tell. And resorbable materials might be the future. And a word of caution with alloplastic implants like titanium is they can result in orbital adherence syndrome in some of the cases. Thank you.